AI is an incredibly promising thing. It could upskill how folks can work. It can help extend you. It can make you more efficient. But it is helpful to put in the time yourself, right? The brain.
I agree.
I'm talking to a doctor.
I agree.
Stop myself before I go too far. But making those connections, learning that pattern recognition, I think there is some value in it. Not to the point where I'm like, hey, everyone should do that, because like one sense you could say, hey, we shouldn't have writing as a tool because human memory would be better. No, we shouldn't go that far. We should have AI as a tool, but we should be intentional about how we use it in training.
Totally. I couldn't agree more. We see that in medical education too. This is Dr. Chethan Sathya. Thank you for joining us for this episode of Northwell Health's 20-Minute Health Talk. We're honored today to be with a true visionary in the space of CMS. We have the director of the CMMI, which is the CMS Innovation Center, with us today, Abe Sutton. Thank you for being with us.
Thank you for having me on, Chethan.
Hope it wasn't too cold outside.
We braved it. I'm used to New York, having spent the first 18 years of my life here, so I can hack it.
Yeah, you were telling me. So you're from Brooklyn.
I'm from Brooklyn.
Okay. So I was curious. So before we get into the nitty gritty about all the incredible work happening at the CMS Innovation Center and payment models and quality of care and cost, you have a background in law, right?
I hold a degree. I wouldn't go so far as saying a background in law. That implies way more practice. I got the law degree.
You got the law degree. So did you ever, at that time, tell me a little bit about your background. Did you envision being involved with CMS, doing healthcare policy? Was that always part of your plan?
So I became passionate about this space in college. I took a class that Zeke Emanuel taught.
Oh, no way.
On the Affordable Care Act and some of the disruption that it was causing in our healthcare system, fueling massive consolidation, how it actually made care less accessible with high deductibles and sort of the impacts that it had. And I walked away from that wanting to learn more about this system and some of the really poor incentives that we have set up in it that are harmful for people. And so I took another class with him, and he's an incredibly entertaining lecturer, and that really sparked my passion for the space. And coming out of undergrad, I went to work at McKinsey, where I worked with healthcare clients, largely health insurers, some pharmaceuticals, some hospitals. And then I joined the first Trump administration to work on health policy and play a relatively junior role coordinating policy across labor, treasury, HHS, just trying to keep things organized, and got to push forward some meaningful stuff in the kidney care space, in broader choice and competition efforts of how you empower people to achieve their health goals, to really get at what's wrong in the system and how to make it better. So it's only after that I went to law school. And partway through law school, I started working on two companies that I started with Adam Bowler, who held this job in the first Trump administration. And so I finished up law school along the way. But by the end, I wasn't taking it too seriously.
Incredible. And so, when you were working at HHS, you had the opportunity to work with Alex Azar, correct?
That's right, yeah. So I got to work with Alex Azar when he was secretary. There were just some incredible folks leading the charge there. Adam Bowler, who I mentioned, who was director of the Innovation Center, Joe Grogan, director of the Domestic Policy Council, and also Brian Blaze, who was head of healthcare at the National Economic Council and was my first boss in government. I spent 18 months really learning from Brian about healthcare markets and how to shape incentives within them. And Brian was very focused on Medicaid and the individual market, and had me focus in largely on Medicare, where he wanted someone to go through and read these hundreds of pages of regulations and summarize them for him and call out the issues to ask for how to approach them. And so it was like a great opportunity to learn and get a grounding in how the regulatory process works in healthcare.
Wow, what an opportunity.
The only way to get a grounding and really do is to apprentice yourself to people who have this expertise, who have been thoughtful around it, and just see how they think and how they learn. It's just an accelerant early on in one's career to get to spend time with people who are incredibly thoughtful and are interested in mentoring others and helping shape their worldview, shape how they approach things, and also give them the grounding and tools and skills they need to make a difference.
Do you wish, when you were summarizing those 100-page documents, do you wish AI was around?
This is one of, I think, the things that people have some angst about in our society, and appropriately so, is if AI could summarize it, will you take on that person to go and summarize the thing for you? For me, I learned a ton from reading those documents because You have to issue, this is the law school language. You have to issue spot. You have to identify what matters. You have to connect it with a philosophical principle to understand, is this aligned or not? You have to understand the economic impact that this will have. If AI had been around, I might not have been given that opportunity. And if I had just relied on AI, I wouldn't necessarily know this inside and out. Now, AI is an incredibly promising thing. It could upskill how folks can work. It can help extend you. It can make you more efficient. But it is helpful to put in the time yourself, right?
It
the
is.
brain.
I agree.
I'm talking to a doctor.
I agree.
So I'm going to stop myself before I go too far. But making those connections, learning that pattern recognition, I think there is some value in it. Not to the point where I'm like, hey, everyone should do that, because one sense you could say, hey, we shouldn't have writing as a tool because human memory would be better. No, we shouldn't go that far. We should have AI as a tool, but we should be intentional about how we use it in training people.
Totally. I couldn't agree more. We see that in medical education too, by the way, right? Reading those longer documents, certainly we're seeing some more retention there. So I totally agree. When you spent time in those years with HHS and so on, did you have certain things that you came in with preconceived notions that, that just your mind was totally changed? Things that you thought were correct about health policy that just you totally learned that was the opposite when you actually spent time there?
I didn't appreciate fully how hard it is to shape the right incentive. Mm-hmm. Let's talk a bit about price transparency. It's an issue that is core in the agenda now. President Trump is committed to ensuring people have access to pricing. One thing that I learned through our efforts then is that it's important that you both have access to information and an incentive to react to and use that information. There's a pretty famous study around CalPERS, the California pension healthcare plan. And so what they had was a reference price for knee replacements. And this study showed that if you do that, people will go to hospitals that charge that price or less, and they will not be willing to go to hospitals that charge more to pay out of pocket without a discernible quality difference, which there really wasn't one that people could detect. And so once California and CalPERS adopted that system, they saw pricing pattern change, where hospitals lowered price to be at the reference price that was willing to be paid. That's the type of behavior change that is enabled when people have access to what the price is that these hospitals would charge, plus an incentive to look at it with, this is all that the insurance will cover. Mm-hmm. Now you have to be intentional about this. If you're missing one half, you could put people in a really bad place. If you're missing the other half, you're having no impact at all. But that's why we look to move forward both at once in a coordinated way, so you've got both halves of the coin. And I try and apply that approach to a number of different policy areas as we think through them. How do you give the right incentive, and how do you make it usable?
Got it. So let's shift gears then. So the two big priorities of your center are to improve quality and decrease cost, right? On the cost side, well, we'll focus there since we were talking about price transparency. What are some of the most impactful things that you're currently doing at your center that are different than what was tried in the past, that might not have worked, to bring down that cost?
I think that some of the most impactful things we could do is really to empower people. We have a lot of models and incentives focused on providers, and that's important. We should do that. But we also need to get at what is the incentive for the person in the room, and how do we get them to engage proactively in their healthcare journey? How do we get them to feel empowered and to take the right step earlier so we prevent disease progression?
You're talking about the patient.
Talking about the patient. What is the incentive for the patient to engage? In the LEAD model, for example, and LEAD is our long-term enhanced accountable care organization design model. A lot of words there, but it's LEAD. Trust me on that.
Acronyms, right? Government.
That's our favorite thing. Though we move away from three-letter acronyms towards these words that have some sort of association. But on LEAD, and we can talk about the naming conventions. LEAD really is about empowering collections of providers to support their patients better. So how does that translate into better incentives to empower patients? Well, lead ACOs could waive cost sharing on certain services if you go to a preferred provider in their network. So suddenly that referral to the specialist isn't a cost barrier for the patient who's enrolled in original Medicare for their Part B services. That's a big change. And I think that'll make a difference in follow-through in getting care. Another flexibility offered is a buy down of the Part D premium, which previously Medicare Advantage plans could do, and original Medicare plans really couldn't do. And what is an original Medicare plan? It's an accountable care organization.
Yeah.
So letting the lead participant buy down Part D premiums is going to change how ACOs are able to engage their patients to get them drug coverage. And if you make it more affordable for somebody to access drugs, you're suddenly making it easier for them to adhere to a drug regimen, which can have dividends for their health if suddenly they're taking the medications they should be on in an adherent manner.
Absolutely. So you're really thinking about it, okay, so thinking about it from the patient standpoint, that makes sense. And then from the system standpoint, there's a conversation there, which we'll come to in a second. But from the clinician standpoint, I'm of course a clinician, right? I'm an implementation scientist by background. So I'm always thinking about usability as well, and what are the incentivizations for physicians? How are you innovating in that realm? Because we all know the great work that's been done, ACOs, value-based care, but at the end of the day, those incentives need to be thought about. What would you say to that?
So there are a couple of things we're doing to try and empower the clinician in their relationship with the patient. For example, within the WISER model, which is around the surge of utilization that we've seen AI drive with revenue cycle management, and that hits original Medicare. So WISER is a response in select areas where there's real abuse and potential for patient harm to do prior authorization in those areas, just within 72 hours to check and make sure it's actually appropriate and adherent to the national coverage determination. But within WISER, there's code carding that is coming online this year, which will mean that the vast majority of clinicians actually don't encounter that once that's stood up, because we actually trust, based on the data, how they're delivering care, you don't need a check on that. That's an important part that I think sets the standards for how we think prior authorization should work actually in Medicare Advantage and commercial plans. And so I think we're setting something that over time the industry will adopt as its standard. I also think that the steps we're taking on other flexibilities available to physicians matter. So there are things that we are giving flexibility on in terms of access to CBD products for pain management within the LEAD model or the REACH model. We have flexibilities around how you engage in care. So your 3-day sniff waiver, which was something that was in REACH that we carried over, that's something that can make a difference for how you want your patients to be directed and engaged in the healthcare system. We'll build in more flexibilities in LEAD and how you could communicate with patients, because there's been a disparity in marketing between Medicare Advantage plans and what an ACO could do to engage with the patient. The other thing I'd call out here is really the access model. And being able to get basically a co-management fee for ingesting data as the patient is engaging with an app, a digital therapeutic, and say, all right, I'm going to change how I engage with this patient and help direct them based off the data I'm receiving, and I'm reimbursed for doing that. That empowers the clinician to really just spend more time with the patient, because they don't need to worry as much around billing for the E&M visit. Like if it's like, oh, I'm engaging with the app and sending a message, and I'm paid for it because of this co-management fee.
Got it. Yeah, I've seen that. You have a renewed focus kind of on having, empowering physicians, healthcare workers to leverage technology within these different payment models, right? So that was one wonderful example, and I think it's important for our listeners to understand too. Do you have some other examples of that, of how physicians might want to care for patients in different ways, like you said, right? They might want to leverage wearables, for example, or different types of technologies, because you can talk about telehealth. How are you thinking about those payment models and how we really start including those in the ecosystem, what we do?
So access is something that'll be a pathway here. It's an outcome-aligned payment. So we're not paying for a particular device or particular type of intervention. We're telling the health tech companies that are participating in access, come in, achieve this outcome. There's a base payment per month. There's also then a certain amount that's linked to the outcome you achieve. And we're going to take all that data and put it on a website. And so as a clinician, you could look at that information and judge, okay, do I want my patients accessing this or not? Is this the right thing or is it not? And then just react to that. And so that is something we're excited about, because I think it's going to let the best solutions rise, and it'll encourage competition. to serve people and empower the clinician in that conversation. But looking beyond that, and this gets at independent practices that join together in ACOs, but also at health systems, to what you alluded to. The LEAD model does some things very intentionally because of the moment we are in as just society. The promise of generative AI to help serve people and expand access while costs fall for that service is tremendous. And we face the question of where the surplus should accumulate in that. Mm-hmm. And part of the answer for us was really the existing healthcare system. And so who has the ability to service people and drive down spend while capturing that margin? Mm-hmm. It's the participant who joins LEAD. A 10-year model without rebasing means that if your spend, as it's expected, is set for a decade, and then you could lower your cost structure while serving more people potentially and engaging them and expanding access such that then revenue rises for the more people you cover. That's the flexible model that lets a health system CFO say, oh, we'll make investments now in trying to lower our costs because it won't degrade our revenue line. Whereas if you're in the classic fee-for-service structure, that doesn't work. Because in the fee-for-service structure, what would happen is, as you become more efficient, you can't bill for as many E&M visits. You're not engaging in those. So there's no reason to adopt these. And so setting up an incentive structure that you could count on, that's not rebased downward, where you have the flexibility to adopt these tools is what matters. And we face the choice of, should we have a code for each AI thing to incentivize adoption? And my answer there was no. Basically 3 broad buckets, and this is a gross oversimplification.
Please.
But 3 broad buckets of what AI can do. One is the administrative tasks. Think revenue cycle management, things that help improve the efficiency of operations in the system or the practice. And there's already an incentive to do that. We don't need to create one specifically. Then there's what I'm describing in LEAD, which is ways that the existing healthcare system could use technology to become more efficient, where if we give them a value-based payment structure, suddenly they'll do it. And that's on clinical delivery, because otherwise each part of clinical delivery is optimized for a fee schedule. And so now we're freeing up local practices and systems just do what's right for the patient. Like, be 2 people in a room and engage with them to keep them healthy. And then the third thing, which was an important one in our view, but also a limited one, is new health tech entrants, people who are not existing parts of the healthcare ecosystem, but may bring some of this technology skill set to the forefront. And for them, the access model is a way to do it, not with broad total cost of care accountability, not displacing that responsibility and investment that really belongs to the existing healthcare system, but a new entrant that could develop new solutions and offer things that they could go direct to consumer, but they could also really, if they want a distribution channel, partner with healthcare systems, partner with practices to push their solutions forward, as long as we make that data very transparent and available.
Interesting. So these new entrants, these are health tech companies, startups?
Yeah, I mean, I think we'll see some people who are in the consumer space.
Yeah.
Like, think about companies that are going direct to consumer and getting cash pay for helping people manage their mental health or stay calm. Or managing other conditions like diabetes. Now those players have a path to market in Medicare.
Got it. So even tech-enabled, access companies and so on, they could theoretically partner with health systems and integrate into this model.
And in fact, we were very intentional in saying that for the first year and a half of access, we're not counting that spend against an ACO's medical expenses. And so there's a good adoption incentive and time period where there's free experimentation for healthcare systems to see what solutions work for them.
That's awesome.
One of the hard things is that our healthcare system is really a healthcare system and not a health system. And that's just the way it is, because we pay for healthcare. We don't pay for health. Now, value-based care, accountable care is supposed to change that, but it's hard to turn a ship in a different direction. And most medical schools in this country still don't have nutrition classes to get at the core of what it means to live a healthy life. And it might be an afterthought on a visit. Oh, you really should work out. There's no follow-through of like, well, are you doing it? And if you seem okay, you're not obese, your doctors be like, oh, you're fine because you're better than the other people who came through. Not thinking through what can you do better and can I encourage and push you.
What are you guys doing that's different than the years before you?
So I think there's a lot of lessons to learn from
Yeah.
the past, decade and a half of the center's history. I don't consider that period a failure. I think that there's a lot of what we did this past year that built on what came before and learned from its lessons. And frankly, at the onset of this experiment, there was a lot that we didn't know.
Yeah.
And so I give a lot of credit to the folks who came before me, who put out creative ideas, different things, and said, let's just try it and see what works. I think the initial era of the center was really a lot of that. Let's see what works, those things. Then there was a second chapter that really began with Adam Bowler and continued under Brad Smith and Liz Fowler, which was broadly continuous of we're going to do more value-based care arrangements. We're shifting on this as our thing to do. We think incentive alignment matters, and they were 100% right on that. And I think that was intentional. We're building on that, emphasizing downside risk a bit more. We're also responding to the moment of what's possible with technology and building that into our portfolio with 2 tech-oriented models in Wiser and Access. We're expanding out on the drug space in a way that we didn't really have before, and broadening up a bit to get at core foundational ideas with Maha Elevate.
Mm-hmm.
A decade ago, I guess it's a bit over a decade ago, the Healthcare Innovation Awards was one of the early models from the center, which sourced ideas for how to intervene in the healthcare system. Maha Elevate is basically an updated version of HICIA. Streamlined, a lower amount of funding because we saw that HICIA really overspent looking back, but said, all right, we know there are interventions that work on improving wellness and improving just lifestyle. Let's see those tested in a Medicare population in a controlled manner, and let's get the data and see if there are broad interventions we could do. So we've re-broadened the aperture, but are doing it in a very data-driven way. Mm-hmm. And one of the things that really matters for us now is ensuring we're staying true to what the data suggests is possible. Because if not, you have to make changes afterwards, which is a disruptive process that undermines confidence in experimentation in our models and could undermine willingness to participate, which we don't want.
Yeah.
And so staying true to, all right, the actuarial numbers say that in the mid-case scenario, this model is very likely to be a saver and improve quality, and therefore be able to be certified and expanded nationwide. That matters, and we're trying to really stick to that.
Got
the
it.
Other thing I would just add is that when I think about success, I don't think about it model by model. Model by model is important because we want to have designs that we put out that we think will work. But we try and take a portfolio view. And the real thing that matters is, do the ultimate impact of the models that we certify and expand outweigh the cost of running all the center and our models? And given that we spend $1.75 trillion a year on Medicare and Medicaid across federal and state, it frankly is very justified to spend money and invest in R&D.
Yeah.
And that's ultimately what the team I lead does.
I love it. That was, I couldn't agree more. I mean, when you talk about innovation, right? Failure is not failure. It's actually what leads to success. I mean, that's where the learning is. If you're not going to take risk, how are you going to actually make a change? And I think we've suffered from that lack of innovation in a lot of other sectors in healthcare and so on. So I totally get it. And some of the names you mentioned that have prior directed the centers, I mean, they've done incredible work, and I think those are the brave steps that are needed to make a better system. You mentioned also evaluation, right? Key. So talk a little bit more about that. How are you evaluating some of these models? I know this is a broad question. Every model is different. But how are you evaluating them? I'm presuming, as you mentioned, technology is also allowing you to do that more in real time at a midpoint, like you said. How are you thinking about that?
So we classically do evaluations once a year. So for each model, the year ends, we have claims run out, we look at the data. And we define before we launch a model what we will look at in an evaluation. Total cost of care, impact on spend is one obvious one. But then we also have defined quality metrics for each model on what matters, whether it's access to care, is it improving or going down, whether it's particular metrics. We're trying to look at more outcome-oriented metrics. Process metrics, while sometimes easier to measure, may not actually get at what we want because they're easier to manipulate. And if you set an incentive for something, you will get that thing. Yeah. It's crazy how well people respond to incentives. It's human nature. But it turns out that doing the process check may become divorced from the natural follow-through outcome that we were hoping it would be connected with. And so we have a great clinical team that is working through what are the quality metrics that should be in our model, and how could we make the model really focus on outcomes. And so we'll set out, all right, hemoglobin A1C is something we should track. We should be looking at blood pressure here. And so the cardio, kidney, metabolic health track of Access is tracking those things. It's harder to measure those things. You need to have a way to collect that information, but setting that up from the design phase that we require participants to meet or reporting standards that we could get that information means that we're in a better position to run the evaluation.
Got it.
And we've got a great team of folks with academic training, folks who have experience running evaluations, who run this procedure, and we did a whole process to examine how we did it in light of new technology, and said, all right, how can we make this more efficient? How can we lower the cost of running one of our evaluations? And how could we potentially do evaluations sooner than we'd otherwise have been able to? So there's one model that we launched last year where we intend to look at data from the first 6 months of this year to do an early evaluation check on how it's
Got
going. And that is an experiment for us. We'll see how that goes. But I think it'll be illuminating when we look at, all right, how did that go? How does it look and compare to the full year? Are there early things we were able to spot? And looking back on that, we'll see, all right, should we do this more broadly? Running more frequent evaluations has more costs, but the cost per evaluation seems to have declined.
Yeah.
And so it could be justifiable.
Okay, that's incredible. So that means that some of your models and initiatives, right, you're going to end earlier if you see those early signals, maybe that they're not working out potentially.
So we tend to try and course correct if we see something that is not working.
Of course, iterate.
Then we'll iterate and make changes. And so that's a lot of what we did early last year. So we came in and we set up teams on the things that we wanted to invest in, where there'd been a plan that had been developed that we helped execute on. But we also went in and did a comprehensive portfolio review, and we saw there were some things that just weren't going to work. I'll call out making care primary, a really well-intentioned model, but given the participation by track and how it was really upside down from what the actuary had assumed, the actuary came back and said there was really no way we could reduce savings. And there was not a clean way to modify it to get at the result. So we'll move it forward in other ways. There are aspects of what it encouraged that LEAD encourages as well, in a way that's more likely to be true to our statutory goals, and therefore be a better way for us to engage with it so we could sustain it. My hope is that what we produced this year is on the mark, well calibrated to meet our statutory requirements, and therefore likely to continue. I'm sure I didn't get everything right, but that's really what my intention was.
Okay. Thank you. You mentioned the MAHA Elevate, right, initiative. Talk through some of those details there, because I know at Northwell, for example, we do consider health as a much broader issue than just the bricks and mortar care that you get within a health system. It is about better food, wellness, exercise, and so on. But talk a little bit about that initiative and how that came to be.
So one of the hard things is that our healthcare system is really a healthcare system and not a health system.
Yeah.
And that's just the way it is, because we pay for healthcare. We don't pay for health. Now, value-based care, accountable care is supposed to change that, but it's hard to turn a ship in a different direction. And most medical schools in this country still don't have nutrition classes to get at the core of what it means to live a healthy life. And it might be an afterthought on a visit. Oh, you really should work out.
Yeah.
There's no follow through of well, are you doing it? And if you seem okay, you're not obese, your doctors be like, oh, you're fine because you're better than the other people who came through. Not thinking through what can you do better and can I encourage and push you? And is it my job to encourage and push you versus just tell you here are your vital signs? MAHA Elevate is an opportunity to step back and hopefully shape what the next decade looks like for us in a similar way to how the Healthcare Innovation Awards led to 4 different model tests, and one of which became certified, and also was really the best data point on health at home that then Congress picked up and ran with, but it came out of the best data on it really came out of an early HICIA grant. So with MAHA Elevate, we're saying, let's step back, do another one of these, see what comes out of it, see what ideas are sparked, but do it in a way that is really focused on functional and lifestyle medicine. Do it in a way that embraces wellness and tries to get people to change the way they behave, the way they eat, and see what impact does that have on a Medicare population on their health outcomes. Titrated appropriately. Hey, we're doing this intervention with this population with these sets of conditions, and we're going to collect data in this way. Giving out 30 of these grants will give us really rich data for folks in my shoes, 4 years from now, to make really informed decisions on what the portfolio should look like in the future. And a lot of what we do is try and generate data to inform future model design. And given the nature of how putting out an experiment, letting people sign up, having it run, collecting data from it, how that lags, there are things that I do that react to data from things started under Patrick Conway.
Yeah.
And there are things that I'm doing now that I hope will inform how somebody a decade from now reacts to the portfolio. I'll call out one other example of this, which is the CMS administered risk arrangements.
Okay.
This is a component of the LEAD model. And in that, rather than us centrally designing that this is what a bundle of care or an episode should look like, we say, you, the ACO, the health system, go and contract with a specialist group or the specialist in your system and design your own episodes. And we, within CMS's payment rails, will administer it. So you define length. Is 30 days, 45 days, 60, 90 the right length? You define what the episode trigger is. You define what code should be included, and you define the payment terms. Give us those information in the standardized contract that we have, and we will administer changes in how original Medicare payments go out. Pretty cool thing about this is I'm going to mine that data.
Oh, yeah.
And I'm going to look at that
Amazing.
to inform future episode design. And when I say I really mean the future Innovation Center team once we've got data from this running. So CARA will launch 1/1/27 as part of LEAD. So, we're under a year out from it, which means that starting in 2028, we'll have the first year of data. Really, with 6 months of claim plan out, it's the second half of 28 that we'll have it. But we might need 2 years of data before we're good. So we're into the next term already before you're really getting meaningful data. And uptake might be slower in year 1, but year 2, people will have had a chance to operationalize this. And so it does take time, but putting in these structures to generate real evidence to inform future design so it can be more intentional is one of the things that I think is our responsibility in the center to do.
Got it. What do you think, so you shifting gears a little bit, you mentioned access earlier, not the access initiative, but let's just talk about healthcare access in general. A lot of buzz and discussion. I know this isn't necessarily under your center, but a lot of buzz about the rural health transformation initiative and the funding that's going out there. What do you think are some of the most important elements of that initiative when it comes to really incorporating technology? Because I know you're in the Innovation Center, right? So how are you guys collaborating with that initiative, thinking about that?
So very closely. Okay. I'll call out that the director of the Office of Rural Health Transformation is an ex-CMMIer that I helped recruit in, and that we took one of the deputy directors in one of the divisions in the Innovation Center, and she's now the deputy director of that office. And part of that was that early on, when Congress was passing this legislation, Dr. Oz turned to me and said, well, how should we approach this? And so this was a time where it was July 4th weekend, and I went home for the weekend with this task assigned to me that I had to come in right after the weekend with all right, how should we allocate funds? What should this look like? What are we actually trying to encourage here? And we developed 5 different key themes that are called out in the Notice of Funding Opportunity. We drew on priorities of the Secretary and the MAHA movement. And we also drew on priorities for supply side liberalization in the healthcare system from the 2018 report on choice and competition in U.S. healthcare markets that Labor, Treasury, and HHS at the time had collaborated on. And we tried to lay out what would it look like to remove supply side restraints and constrictions and help encourage people to live healthier lives using levers within state authority. We said, well, let's incentivize states to adopt these policies in order to try and lift up the standard. And a lot of those relate to technology and removing barriers of entry and ensuring new investments. And they relate to things like the workforce that we have in healthcare and upskilling folks and scope of practice reform and removing barriers of entry like certificate of needs. When I think about why it's been so hard to access a provider in a rural area, a lot of it is a headcount issue. are you really able to sustain all these different specialists in a community? The community is just by population will not generate a sufficient number of visits to fill someone's schedule. Well, the classic answer before new technology was, well, we could pay a bit more in rural areas, a plus up to make it work. And that works to a point. But at a certain area where you're even more rural, it's hard.
Yeah.
And it's not the most efficient answer.
Yeah.
So what if instead of doing that, we helped the primary care physician access specialist expertise from other places?
Yeah.
One answer to that, a telehealth answer to that is, you Skype in the specialist and then they're able to do it. You have them consult. Another answer is these extenders that help the internal medicine doctor actually be the specialist. Both these, one benefit of that is you don't have to wait for the specialist. You don't have the 6 months wait, which in our Medicaid network, it's really hard because of Medicaid's payment rates. Even if it looks like on paper you have this really rich benefit, you can't use it at all because you can't get access to people who will see you and serve you. And that makes the system really hard to navigate. But technology can help move us away from that. And so giving states the tools and incentives to adopt this and let it flourish really matters. And that could take the form of, we should opt into interstate compacts such that licensure flows across state lines. So it's easier to start one of these companies that serves people and serves federally qualified health centers, rural health centers, and lets them access folks with the training and skill sets that they need.
Yeah.
I mean, there's so many really rich ideas that came in the applications that the state submitted to that office, which is part of the Center for Medicaid and CHIP Services. Dan Broman and team are doing a great job. They review these applications, they approve them, they met the statutory deadline for it and got money to states so that states can make these investments. I'm excited, particularly about how many of the ideas that came in really resonate with what we're pushing forward in the AHEAD model, for example, about engaging states and in other interventions we're doing.
It sounds like, just hearing you and looking at some of those applications and what's publicly available, I mean, it seems like it aligns really, really nicely. And as a specialist myself, I mean, it's always struck me how much we can also do that doesn't require bricks and mortar, right? The days that we have to truly examine a patient are not really there anymore. I think even as a surgeon, right? I mean, it's ridiculous that someone has to travel 3 hours to see me, then to be told that either I'm the wrong specialist, they got the wrong tests, or they need more tests, and to then come back in 3 months, and then for me to schedule surgery 6 months later. That whole workflow and process, I think, has the ability to be transformed and disrupted through what you're doing. So,
and the wait time to get the appointment, then you drive the hours to see you. It's just so...
The barriers are immense.
I mean, I remember when my daughter was born. It was something that it turns out was minor, was resolvable, but the scare that we had of, Vanderbilt can't get us in on this time period. All right, but we could go out to Murfreesboro, we were living in Tennessee at the time, in Nashville, and there somebody is able to see us next week. And so, we did a scan. I'm holding down my newborn daughter as this is taken, and she's crying as they're doing the scan. And in the end, it resolved. But the wait to then go 4 weeks later and then see it again, and we have great healthcare, and we're able to get access in the system and know how to navigate it. But it was just scary.
Still hard.
And engaging with the healthcare system is something that people do from a state of fear. Not because the healthcare system is intentionally trying to engineer that, but just because you're in a vulnerable place and, you work in the healthcare system day in and day out, but the person who's engaging with you, this is like a once a year thing, or this is a once every 5 year thing, or something they haven't thought about, but suddenly they're engaging with, and they're vulnerable, and they're scared, and making that process easy and accessible really could transform people's experiences.
You only realize that once your kids or yourself go to a hospital, right? Truly. So we're almost finished here, Abe. Really, really appreciate your time. I wanted to close on one or two kind of bigger questions here. Every time I have these conversations, right, with individuals like you, I'm incredibly energized. Amazing things are happening. It seems like there's a lot of action, a lot of transformation, initiatives are being implemented. But when you kind of look at the media, you take a step back, social media and so on, a lot of discourse tends to be around doom and gloom. Is there anything else you want to add? I mean, I want to give you a chance to kind of respond as to all the incredible work that's happening and how people should think about it, because it's really amazing what you guys are doing.
I mean, you're right. a lot of the discourse is discouraging. And a lot of the trends in our healthcare system have been discouraging. And it's understandable why. But there's a lot that is encouraging as well. Like starting on the pure clinical side of the breakthroughs we have, of what we can do for people. Like the outlook for somebody with cancer today versus the outlook a decade ago. The new drugs are, these are miracles. There's no other word for it. The ways that we're able to support engagement of the healthcare workforce with patients, I think we're trying to get back to the era of, the small town doc and the community that they know well, rather than the doc with 3,000 plus patients on panel.
Yeah.
I think that I'm able to be optimistic because I'm starting to see around the curve. I'm starting to see a system where we combine the marvels of modern medicine with the relationships to help you navigate that system. And it was hard to get there because we went from good relationships to modernization and bureaucratization of the healthcare system. And now we're like, all right, let's keep the modernization and push it forward on, at lightning speed while moving into the local, the connection, the emotional relationships to the system. And I'm starting to see it. I see our systems as moving away from a centrally defined Washington fee schedule to say, let's empower the local community. I'm seeing us try to set up the incentives so that there's a go-to-market for these marvels in a way that actually orients towards people. It's often said that the original sin of the US healthcare system is the creation of the tax exclusion for employer-sponsored insurance, stemming out of the whole exclusion from the wage controls in World War II and all that history. We're trying to move to a system where the person is seen as a person and not as a commodity to move. And I think we're getting there.
That's amazing. And that's something all Americans want, right? All individuals in the world want. Truly appreciate your time, Abe. It's conversations like this that matter, right? We want folks to know about the incredible work that's happening in our government. So thank you so much.
No, thank you for having me on. It's a privilege to join you and the Northwell team on this and in other conversations. We really care about understanding how things impact healthcare systems, how things impact the healthcare system and the American people, and it's dialogue that helps inform our approach to future rulemaking and how we should approach convening folks in the industry. And so I'm just grateful for the time to sit down with you. Thank you.
Totally, me too. Thank you.